احنا الحين 8 و10 تقريبا. تمام. طيب اجل زين، اجل نبدا نتوكل على الله. اوكي زين، بسم الله الرحمن الرحيم. انا الدكتور محمد الخويطر. We are going to talk today about two topics: the chronic kidney disease and how to approach arterial blood gases or acid-base disorders, how to read ABGs, how to read arterial blood gases. So we'll talk about the first topic, the chronic kidney disease. And guys, if you want to ask about anything, you can just drop your question in the message box, and I will be able to answer this, inshallah, answer all of the questions, inshallah. Okay, so chronic kidney disease. This is the objectives. Okay, so let's first of all define the chronic kidney disease. What do we mean by chronic kidney disease? Chronic kidney disease, it means that I have persistent damage. Yani, what do we mean by persistent damage? I'm not referring to an acute kind of injury. No, this is a permanent, a persistent damage. And this damage could be either structural or functional. كيف يعني structural or functional? Structural يعني مثلا having a kidney cyst, for example, having a sclerosis, for example, in the kidney biopsy. That means structural. Functional معناته يا يكون عندي albuminuria أو يكون عندي high creatinine. So the filtration is not okay, all right? So this is functional damage of the kidney. And it is persistent. What do I mean by persistent? It's present for more than or equal to 3 months, okay? With or without reduced GFR. يعني مو بالضرورة يكون دائما عندي high creatinine عشان أقول this is a chronic kidney disease. I may have polycystic kidney disease in early stages with normal creatinine, but yet I call these groups of diseases chronic kidney disease. Another definition is having a GFR of less than 60 ml per minute for more than or equal to 3 months with or without any structural kidney damage. Okay. As we know, we have a classification for chronic kidney disease. صح ولا لا؟ واحدة من أشهر الكلاسيفيكيشنها هي classification of CKD stage 1, stage 2, stage 3, stage 4, stage 5. صح ولا لا؟ طيب, what do we mean by stage 1? Okay, stage 1 or G1, huh? When you have a normal GFR, I would say, okay, but in addition you have structural changes. كيف يعني؟ يعني عندي cysts في الكدني أو عندي hematuria مثلا, huh? But the kidney function is still okay, the filtration is still okay, the creatinine is normal, the GFR is more than 90. I call these diseases stage 1 chronic kidney disease. G2, when you have a low GFR between 60 to 90, again, with evidence of damage, يعني يكون عندي cysts, hematuria, albuminuria, إلى آخره. So لو تلاحظون إنه first two stages G1 and G2 يشترط إنه يكون عندي دائما structural changes. Okay, structural changes أو hematuria أو albuminuria in order to call them chronic kidney disease stage 1 or stage 2. بينما stage 3, regardless whether you have structural abnormalities ولا لا, it is CKD. Stage 3A, خلينا نقول stage 3, G3 when you have, okay, مرة ثانية. Stage 3 when the GFR is between 30 and 60. We subdivide stage 3 إلى two types. Stage 3A, stage 3B. Stage 3A when the GFR من 45 إلى 60. بينما stage 3B لما يكون ال GFR من 30 إلى 45. بعدين نوصل لstage 4. Stage 4 اللي هي من 15 ل 30 and stage 5 when it is less than 15. Okay? Is that clear? Is the classification of CKD clear? I want to see answers, guys. شوفكم بالبوكس, بالمسج بوكس. طيب قسموا المرحله ثلاثه لانه when it is 3 يعني G3B من 30 ل 45 you have to be careful من ناحيه البلود تيست البلود بريشر مانجمنت الفريكونسي of seeing the patients in the outpatient clinic. you will order مثلا PTH الى غير ذلك. ف 3B ليش هنا بالذات قسموها؟ لانه 3B خلاص you start to have significant chronic kidney disease, okay, and that's why you have to be يعني more attention to it. تمام توكلنا على الله. طبعا how about the albuminuria؟ هل في albuminuria categories in chronic kidney disease؟ اي نعم. when the albuminuria is normal less than 30 they call it A1, okay. لكن when there is microalbuminuria they call it A2 اللي هي between 30 to 300 milligram per 24 hours. او اذا بتسويها بالالبومين تو كرياتين ريشيو بتكون بالمليغرام per gram 30 to 300 milligram per gram. All right, so you call this A2. A3 when it is macroalbuminuria لما يكون عندي overt nephropathy لما يكون الالبومين is more than 300 milligram per day او يكون more than 300 milligram per gram. اوكي طبعا ليش نقول احنا مليغرام per gram؟ احنا الجرام هذا نقصد فيه الكرياتينين والافريج excretion of creatinine in the urine per day is 1 gram. زين فهذه لو تلاحظونها تقريبا مساويه لهذه. طيب اوكي so again the classification of chronic kidney disease based on the albuminuria. If the albuminuria is less than 30 milligram per gram or less than 30 milligram per 24 hours we call this A1. A2 when it is macroalbuminuria from 30 to 300 milligram per hour او اذا بتحسب الالبومين تو كرياتين ريشيو تقول 30 to 300 milligram per gram. او اذا كان عندي macroalbuminuria او overt nephropathy فهنا الالبومينوريا بتكون more than 303 milligram and I call this A3. Okay, I call it A3. Is that clear? Is that clear, guys? Okay. Good. Wait. Why I do these things؟ يعني ليش انا جالس اسبب قلق؟ اقول لك 3B، اقول لك في A1 وفي A2 وفي A3 because I'll show you this diagram actually. When you have G1 and G2 look at the risk of progression green. So this is we don't call it CKD لانه انا اشترط انه لما يكون عندي stage 1 و stage 2 I only call it stage 1 and stage 2 if I have albuminuria or structural changes or hematuria. زين فلو تلاحظون هنا it is not CKD لانها ما في structural changes. اوكي وعاده يكون هنا البروجنوسيس is okay great. طيب لاحظ معي هنا مثلا في stage 2 لما يكون عندي microalbuminuria طبعا هنا اليونت المستخدمه مليغرام بير ملي مول. ارجع لكم مره ثانيه على الجدول. هنا هذه اليونت المستخدمه مليغرام بير ملي مول. اوكي طيب بينما هنا مليغرام بير جرام. زين فهنا احنا we're referring to the milligram per millimole. فاذا كانت عندي ماكرو البومينوريا في ستيج 1 وستيج 2 صارت اصفر معناته الريسك اوف بروجريشن يعني بسيط لكن when it is orange this is moderate. اوكي moderate يعني risk of progression. تمام لما يكون عندي stage 1 stage 2 but with macroalbuminuria. لكن look at this يوم قلنا احنا ليش قسمنا stage A و stage B لأنها تختلف معنا في مسألة البروجنوسيس وبالتالي تختلف معنا في مسألة الاوردرز اوف ذا tests والفولو اب. لما يكون عندي 3A when I have macroalbuminuria the risk of progression is high. Okay when I have 3B when you have microalbuminuria the risk of progression is high. Okay. أما إذا كان عندي طبعا severe reduction in the GFR stage 4, whether or not you have an albuminuria, the risk of progression is high. وأكيد إن risk of progression يزيد لو كان عندك significant macroalbuminuria. Okay. So do you know now why I classify chronic kidney diseases? Okay, I want to predict the prognosis. I want to act early on. I want to do my best to modify the risks as much as I can in order to slow the progression. Okay, واضح جدا إنه حاجتين اللي associated with high risk of progression أو increasing risk of progression الالبومينوريا واحد، اثنين الGFR. Okay, is that clear, guys? طيب بسألكم سؤال، لو كان المريض عنده albuminuria of let's say 500 ملغ per gram، زين، او اذا بستخدم الملغ per millimole بقول more than 50 ملغ per millimole، تمام، والجي اف ار حقه 35. Which class is this? GFR 35, albuminuria of more than 500 ملغ per gram. $35 يعني 3B صح ولا لا؟ يعني G3B سوري G3B صح ولا لا؟ G3B ولا لا؟ طيب وهو هنا A3، فإذا أنت يعني would classify it would say G3BA3 G3BA3. طيب لو كان الجي اف ار عنده 70 زين والالبومينوريا is only 20 ملغ per millimole أو 200 ملغ per gram. What do you call this class? G2A2. أحسنت معتز. G2A2. طيب لما يكون عندي الجي اف ار 14 and he has no albuminuria is less than 3, what do you call this? So GFR is less than 15, this is G5, right? And albuminuria is less than 3, so this is A1, so you call it G5A1. G5A1. Again, what is the idea of doing this? What is the aim behind doing this classification? In order to stratify the risk, stratify the risk, so you should, based on that, do your management plan accordingly. Right. So why we want to classify it? To determine the risk of progression, and that would have an impact on the clinical care. كيف يعني? Number of visits, frequency of blood work, workup for cardiac diseases, avoiding, for example, contrast, IV contrast, etc. Okay, anyone can tell me what are the risk factors for chronic kidney diseases? Diabetes, صح أحمد عبد العزيز. أحمد, hypertension, yes. Family history, صح, family history of renal disease. طيب. So the main two risk factors for chronic kidney disease in our society are diabetes and hypertension. Both are the leading cause of end-stage renal disease in our society. Okay. هذه مثلا إحصائية مركز زراعة الأعضاء عندنا. لاحظوا إنه أسباب فشل الكلوي النهائي هذول عند المرضى اللي هم يسوون هيمودياليسيس، هيمودياليسيس تقريبا 40% either hypertension or chronic kidney disease. Okay. Glomerular diseases, if you have a glomerular disease, واحد عنده IgA, he's at risk of having a progression, صح ولا لا؟ واحد عنده lupus nephritis, he will be at risk of having chronic kidney disease. So glomerular diseases is a risk factor for that. Tubular interstitial disease, واحد عنده recurrent obstructive uropathy, for example. واحد عنده recurrent urinary tract infection, especially at young age. خصوصا اللي عندهم vesico-ureteric reflux, they will have a problem من ناحية إنه they may be at risk of having a progression of chronic kidney disease. Drug toxicity, واحد ياخذ lithium for long time, for years, he will be at risk of having chronic kidney disease. أيضا having a family history for cystic kidney diseases مثل adult onset polycystic kidney disease, those patients will be at risk of having chronic kidney disease. Genetic diseases مثل polycystic kidney disease ومثل Alport syndrome, also they will be at risk of having chronic kidney disease. Like, what are the complications of chronic kidney diseases? Hypertension, طيب, okay. Renal failure, anemia, ممتاز. How about the bones? No, not liver toxicity. How about the bone? Renal osteodystrophy. Okay. So uremia. So when you have very high toxins in your body, that would result in symptoms that may result in symptoms suggestive of uremia. What are the symptoms that suggestive of uremia, guys? Symptoms suggestive of uremia. Nausea, vomiting, itchiness. Huh? What are the signs of uremia? Altered level of consciousness. Huh? Uremic pericarditis, يعني تحس ببريكارديال رب. ها؟ تسمع بريكارديال رب. ها؟ Okay. So decreased oral intake, nausea, vomiting, weight loss, pruritus, pericarditis, cardiomyopathy, and CNS disturbance. Okay. In addition, volume overload, صح, and electrolyte imbalance. What you are afraid of is having hyperkalemia, for example, potassium of 7, which could be fatal. Am I right? Yeah. Okay. Severe metabolic acidosis as well. Severe metabolic acidosis is a risk factor, is one of the complications of chronic kidney disease. And if it fails to respond to the medical management, then you will do dialysis for the patients. Okay. So we said anemia. What are the causes of anemia and chronic kidney diseases? What do you think, guys? Why I do have anemia in chronic kidney disease, in advanced kidney disease? وش في الاريثروبويتين معتز؟ Okay, why I do have erythropoietin deficiency? Erythropoietin is produced by the kidney, right? And it's produced by the kidney. So if the kidney function is not good, you will not be able to produce this erythropoietin. And erythropoietin would stimulate the production of RBCs from the bone marrow, right? So if you don't have erythropoietin, you will not have the stimulus to the bone marrow, all right? And as a result, no more RBCs are produced, low hemoglobin. Absolutely right. طيب. طبعا in addition, uremic induced inhibit, with uremia, you will have toxins that inhibit erythropoiesis. So it is not only deficiency of erythropoietin, but also the erythropoiesis, the process, عملية الإنتاج تقل inhibited by the presence of some toxins as well. أيضا الار بي سي span اللي احنا نعرفها 120 يوم. It is short in advanced kidney disease, likely due to the uremia. Okay. طيب. High hepcidin. Okay, this is another factor why I do have anemia in advanced kidney disease. All right. Okay. What is hepcidin? It is the main hormone responsible for maintaining systemic iron hemostasis. Okay. So it is high in chronic kidney disease, and that would prevent actually the absorption of the iron from the gut. Okay. Why the hepcidin is high? The hepcidin is high in chronic kidney disease due to reduced clearance, number one. Number two, because of the high cytokines which will induce the hepcidin. Okay. All right. Look at this picture. So the hepcidin, what it will do, it will block the ferroportin. Ferroportin is the channel through which the iron will get absorbed. يعني مثلا هنا في الintestine, this is the intestinal channel. So the ferroportin here is the channel through which the iron will pass. The hepcidin will block it. All right. The hepcidin will block it from the hepatocyte, from the iron storage, right? If you need iron, you will take it from the storage if you don't have iron in the serum, but that would be blocked because hepcidin is high. Okay. The absorption will be prevented because hepcidin is high. Why hepcidin is high in advanced kidney disease? Due to the low GFR, number one, due to the high inflammatory markers that which would actually enhance and induce the production of hepcidin. So as a result, you will have anemia, and this anemia is usually normocytic, normochromic. Is that clear? Shall I move? I want to see more answers. شباب تفاعلوا معي. ممتاز يعطيكم العافية. More answers, please. If it is not clear, I can go back and explain it again. Okay. تمام. So what are the other complications of chronic kidney disease? قلنا bone disease, صح? Renal osteodystrophy. Why? Why? Because we have secondary hyperparathyroidism. What do you mean by that? Well, طيب وش اللي يصير عندي in advanced kidney disease؟ يصير عندي hypocalcemia and hyperphosphatemia, and I have reduced production of 1-alpha hydroxylase enzymes. The 1-alpha hydroxylase enzymes is responsible for converting the vitamin D from the inactive form to the active form. So if I don't have this enzyme because of the poor kidney function, that would affect the calcium absorption. So that's one of the reasons why I have hypocalcemia, right? Number one. Number two, why I do have hyperphosphatemia. ليش عندي high phosphorus? I have high phosphorus because 65% of the phosphate is getting secreted through the kidney. And if this gate is closed, the phosphorus will accumulate in my body. Okay, so this is a reason, the main reason for hyperphosphatemia and chronic kidney disease. Like, what should you do when you have high phosphorus? How would our body would react to that? You have high level of phosphorus, right? So you will try to minimize this phosphorus, صح ولا لا? And one of the ways to minimize it is by binding to the calcium. So the calcium will get attached to the phosphorus in order to prevent its absorption. Okay, that would consume the calcium. That would consume the calcium and would result in hypocalcemia. Okay, so ناخذها مرة ثانية بمثال واضح. تخيلوا عندي إنه هذا النورمال level. Okay, ولكن in advanced kidney disease, the phosphorus is significantly high. Why? Because 65% to 70% of the phosphorus get excreted through the kidney. Okay, the kidney is not functioning well. The phosphorus cannot get anywhere but accumulating in the body. Okay, so I have that much of phosphorus. Okay, and I know that 20% of the calcium will get excreted through the kidney. So if the kidney is not functioning well, I may have normal or high normal calcium in my mind. This is how would I look at it. صح ولا لا? But what should I do to minimize the phosphorus? I want to minimize the phosphorus. So let's say that much of phosphorus will bind to that much of calcium. Okay, and that would result in still high phosphorus. I can't manage 65%. It's a lot. It's a high load, huh? Unless I do medical intervention, huh? Unless I give medications. So this is the end result. High phosphorus, still you have the high phosphorus, but you have low calcium. Okay, so that's another reason for hypocalcemia in advanced kidney disease. Okay, what would happen to the parathyroid hormone if the phosphorus is high and the calcium is low? PTH will go up, right? The PTH will go up, and that would result in bone resorption. صح? PTH will act on the bones to mobilize the calcium and phosphorus, and that will weaken the bone, and that would result in renal osteodystrophy. Okay. Number two, the parathyroid hormone, it will increase the tubular reabsorption of calcium. انت لما يكون عندك اللو كالسيوم that would sense الباراثيرويد جلاند، والباراثيرويد جلاند تطلع لك الباراثيرويد هرمون، والباراثيرويد هرمون بينتبه ان الكالسيوم از لو، وبالتالي بيحرك لك الكالسيوم من البونز الاحتياطي، ها بيجيبها من البونز الى البلد، وايضا will increase reabsorption of the calcium من التبيونز. هذا المفروض اللي يصير عندي طبيعيا. لكن when you have advanced kidney disease, do you think the reabsorption of the calcium from the tubules will be okay? No. No, I'm not expecting that. So you will still have low calcium in the chronic kidney, in the advanced, very advanced chronic kidney disease. Okay. And you will still have high PTH, and the bone resorption will just keep going, and that would weaken the bone. Okay. Like it also, the PTH inhibits tubular reabsorption of phosphorus. Okay. It will enhance the phosphorus excretion. And that's true. Unless I have advanced kidney disease, then there will be a problem here. The phosphorus will not be excreted because the tubules are not functioning well. So the phosphorus will be still high. So the end result, you're doing bone resorption, more calcium and phosphorus will move, but you will not be able to reabsorb the calcium, and you will not be able to enhance the phosphorus excretion, and result high PTH, low calcium, high phosphorus. Is that clear? وهذا بدوره يؤدي إلى renal osteodystrophy أو secondary hyperparathyroidism. Is that clear, guys? سب لحظة شوي شباب. كريدي الكريدي هذا مكتوب والله ما ادري يا هلا وسهلا في السكرتارية ممكن اذا انت حابب تتواصل معها ما بعد جاوب يجون الله يحفظك. طيب again so احنا قلنا انه الكالسيوم is low and there are two reasons for low calcium in the blood in advanced kidney disease. اول واحد انه high phosphorus. When you have high phosphorus, the phosphorus will bind to the calcium وهذا will consume the calcium will be low. Number one. Number two, 1 alpha hydroxylase enzyme. The 1 alpha hydroxylase enzyme it will not be produced in the kidney. وهذا يأثر على activation of the vitamin D. Vitamin D is responsible for absorption of the calcium from the gut. Then I have hypocalcemia and I have high phosphorus. Right? ليش high phosphorus؟ لأنه the gate is closed. Okay. The main way of getting rid of the phosphorus is by the kidney, and the kidney is not functioning well. The kidney is not excreting the phosphorus out. So that's why I will have high phosphorus. So having high phosphorus and low calcium will stimulate the parathyroid hormone. صح? That will sense the parathyroid gland. The parathyroid gland receptors will start to produce, will sense the glands, والglands will produce the PTH, parathyroid hormone. الباراثايرويد هرمون وش بيسوي؟ بيشتغل على bone resorption، يحاول ياخذ من الاحتياط اللي عندي، بس هذا بيسحب كالسيوم وفوسفورس both. اوكي؟ طيب الكالسيوم will bind to the phosphorus. Still I have low calcium, still I have high phosphorus. طيب when you have high phosphorus المفروض ان الباراثايرويد هرمون act on the kidney to enhance the excretion of the phosphorus. But the kidney will not respond very well to the PTH because there are tubular dysfunction because of the advanced kidney disease. So the phosphaturia will not be enhanced. واحد. اثنين, the PTH also will act on the kidney to reabsorb the calcium علشان ما أفقد الكالسيوم كثير. لكن this is not happening. Again, why? Because the tubular function is not okay. I will not reabsorb the calcium in an appropriate way. Okay? So that's why I have hypocalcemia, hyperphosphatemia, and still high PTH. طبعا PTH also will stimulate it will stimulate the 1-alpha hydroxylase enzyme. But again, the 1-alpha hydroxylase enzyme is not going to be produced by the kidney. Okay? Clear? ها شباب عدي؟ تمام. Okay. Renal osteodystrophy is the end result. هنا مثلا عندي renal osteodystrophy لو تشوفون البونز are يعني ها osteopenia very clear صح ولا لا؟ الاوستيوبينيا here is very clear. ما ادري تبون اعطيكم دقيقة على الكود ولا كيف؟ ولا واصل يا شباب؟ اعطيكم دقيقة دقيقتين؟ واحد يرد علي تكفون.
اي دكتور لانه باقي دقيقتين على التحضير وينتهي.
خلاص اعطيكم دقيقتين الله يحفظكم.
الله خير.
طيب توكلنا على الله. So renal osteodystrophy, what do you mean by renal osteodystrophy؟ طبعا مثلا زي البيكتشر هذه إذا أنتم شايفين معي هنا في significant and severe osteopenia. So this is one of the signs of renal osteodystrophy. هنا عندي لو تشوفون زي السيست هذا يسمونه brown tumor. طبعا it's not malignant tumor, no, it is a cystic changes تصير مع advanced kidney disease if the bone mineral disease activity is not well controlled. يصير عندي brown tumor أو cystic changes. okay. هذه sign. وش نسمي الساين هذه؟ أحد عنده فكرة؟ أحد عنده فكرة؟
جيرسي ساين.
جيرسي باسل صح. يعني كيف يعني؟
نفس القميص اللي يكون مخطط نفس اللعيبة وهذا.
إيه تعرف أي فريق يلبس مخطط؟
لا عاد هنا لا.
إيه في الكورة في سلتك صح؟ سلتك الإيرلندي يلبس المخطط اللي خطوط بالعرض. طبعا اذا تشوفون الفيرتبري هنا المفروض انها تكون كلها بنفس الدنسيتي صح ولا لا؟ لكن لو تلاحظون هنا في دائما خط في الوسط. هذه تشبه جيرسي الشركه. زين الشركه طبعا كانت اسمها روجر يسمونها روجر جيرسي سباين او روجر جيرسي ساين. اوكي بالطريقه هذه. هذه one of the signs of renal osteodystrophy. طيب تكلمنا عن الcomplications of CKD، تكلمنا عن الأنيميا وقلنا إنه الأنيميا I have an iron deficiency. الأيرون will not be reabsorbed very well لأنه الهيبسيدين is high صح ولا لا؟ وقلنا إنه الأيرون is low أيضا because we are not having erythropoietin, we're not producing the RBCs from the bone marrow because of the low erythropoietin. وقلنا أيضا erythropoiesis itself is affected because of the high level of toxins. بعدين تكلمنا عن البون mineral disease وقلنا إنه I have high PTH, secondary hyperparathyroidism. I will have a continuous bone resorption because of the low calcium and high phosphorus, and that would result in renal osteodystrophy. خلونا نتكلم عن الحين عن the third complication, which is coronary heart disease. Having kidney disease will increase the risk for cardiovascular disease by 5 times in comparison with the normal population. Okay, so it is quite significant problem, and that's why when you have a patient with albuminuria, you have to do your best to get the blood pressure under control, to lower the albuminuria. When you have a patient with chronic kidney disease, you have to do your best to get the blood pressure under control, the control of the diabetes, modify the risk for coronary heart disease, stop smoking cessation, doing lifestyle modification, weight reduction إلى آخره. أوكي. طيب. طبعا في أشياء تصير لنا with advanced chronic kidney disease when the GFR is less than 15. يبدأ البيشنت عنده neuropathy، ممكن malnutrition and weight loss، أيضا decreased quality of life، fatigue all the time, low level of energy. Okay. إلى آخره. زين. طيب, how would you manage patients with chronic kidney disease? How would you manage patients with chronic kidney disease? You will control the underlying causes, right? So, for example, you will work on preventing the stones recurrence. يعني واحد عنده stones recurrence، احنا عارفين انه recurrent stones may result in tubulointerstitial disease. طبعا في اقل الناس، مو اكثر الناس يجيهم renal stones وحتى تكون recurrent, but they will not end up by having end-stage disease. لكن في minority of those patients who have recurrent kind of stones, they will have end-stage disease. So in order to prevent this from being happening, I will do my best to prevent the stones recurrence. Okay. So take more, let's say, more fluid, more water, في restriction معين على الدايت إلى آخره. Okay. أيضا I would try my best to slow the progression. Okay, how would I slow the progression? يعني patients مثلا عنده diabetes, I will try to get the blood sugar under control early on, صح ولا لا? In order to prevent long-term complications. I will try my best also to get the blood pressure under control, because that would also improve and that would also slow the progression إلى آخره. طيب أيضا الاستراتيجية الثالثة إنه prepare the patient for renal replacement therapy enough time before uremia symptoms occur. يعني مو معقول انه يكون عندك advanced kidney disease وتشوف الكرونيك kidney disease تقل ولا تسوي اي شيء لين يدخل البيشنتس في uremia ويروح للامرجنسي he's sick having vomiting ودايريا vomiting ونازيا وبيريكارديال رب وعنده pulmonary edema وفيري high blood pressure وتسوي له central line عشان تسوي له dialysis والبيشنت may die لانه he has a lot of things going on لا من ناحية الفوليوم ولا من ناحية اليوريميا لا we have to plan that ahead of time before before reaching this stage. فإحنا عادة لما يكون البيشنت يوصل ل GFR of 20 or less نبدأ نتكلم عن الرينال ريبليسمنت ثيرابي. عندنا احنا الكدني ترانسبلانت، عندنا البروتينيال dialysis، عندنا الهيمودياليسيس. We sit with the patients, we explain to the patients these things، ونوريه فيديو ونخليه يجي يسمع الكوردينيتور الاديوكيتور وإذا عنده أي أسئلة إذا عنده أي شيء، وبعدين يختار الطريقة. إذا اختار الطريقة we act based on that. قال والله أنا عندي، وهذا الشيء اللي احنا نشجعه إذا ما كان في contraindication اللي هو renal transplant. يقول والله مثلا أنا عندي أخوي، أنا عندي أختي، أنا عندي ولدي، أنا عندي بنتي، they can donate for me, so we refer them to the transplant center where they will do the workup, okay, and they make sure that they match, okay, so they keep following him until he reach around the stage where he will require renal transplant. Then the transplant will be planned ahead of time. لا والله أنا أبغى hemodialysis. طيب we'll do the fistula, we'll create the arteriovenous fistula. والarteriovenous fistula هذه بتاخذ لها 6 إلى 8 أسابيع 6 إلى 8 أسابيع عشان تكون mature enough to be used، بدل ما أحط لك أنا لاين وخليك at risk of having bacteremia وسبسس وانفكشن وانفكتيف endocarditis إلى غير ذلك. لا أنا أبغى أسوي لك الفستلة، بس لازم تعرف وأعرف إن الفستلة تاخذ لها 8 weeks for maturation. I can't use it within these 8 weeks. وبالتالي I have to keep that in my mind. I have to plan the dialysis or renal replacement therapy ahead of time قبل ما يوصل للمريض ل end stage renal disease أو الهيم أو يعني requiring dialysis أو renal replacement therapy. Okay, so كيف I get the blood pressure under control? Well, I get the blood pressure under 130/80. Okay, I will use RAS blockade if the patient has proteinuria. Okay, independent of the blood pressure. يعني لو بشرط انه ما يدخل البيشنت في hypertension اكيد. يعني واحد عنده blood pressure 130/80 هذا within the target صح؟ لكن عنده proteinuria. I may start him on RAS blockade يعني زي الACE وزي الARBs واحد منهم small doses وأراقب ال blood pressure. So it is independent of the blood pressure. طبعا أكيد لو كان blood pressure is high, the first agent that I want to use is ACE or ARBs in order to decrease the proteinuria. Okay, طيب. أيضا if the patient is diabetic, you will try your best to get the blood sugar under control with A1C of less than 7%. You would also try to modify the risk for coronary artery disease, trying to keep the LDL less than 2, especially if the patient is known to have ischemic heart disease. طبعا قلل من الصوديوم في الدايت علشان ما يرتفع البلد بريشر عنده وعشان ما يزيد عليه الفوليوم ويدخل في الفوليوم اوفرلود. يقلل من البروتينوريا من البروتين diet as well. Okay. طبعا in addition to avoid anything that could affect the kidney زي مثلا non-steroidal anti-inflammatory drugs. We don't like them, especially when the patient has advanced kidney disease. Okay. IV contrast إلا إذا كانت يعني something you must do it and you don't have an alternative to. Okay. لكن الأصل إنك you avoid حتى ال IV contrast. Okay. مثل ما قلنا عن renal replacement therapy عندنا renal transplant, and this is our choice unless there is contraindication, hemodialysis, and keep in mind that hemodialysis will require fistula creation and the fistula creation will take 8 weeks to get matured, or peritoneal dialysis. Okay, thank you so much guys. هل أحد عنده أي سؤال؟ سبعين بالوحدة الثانية ما أدري والله، لازم ما تحضرني والله يا أحمد. تمام، إذا ما خانتني الذاكرة هي 100 أعتقد، لكنه ماني متأكد. So you have to convert it. طيب، حياكم الله. في أي سؤال؟ طيب نبدأ 9:05 تقريبا، شو رايكم؟ ناخذ المحاضرة الثانية الساعة 9:05. أوكي يا شباب؟ تمام. I'm not gonna leave or end the meeting. تمام. I will يعني 7 minutes إن شاء الله we'll be back. ها اللي بياخذ منكم قهوة ولا شيء ولا بيطامر شوي، ها يعيد التركيز. زين، الله يعطيكم العافية.
مهمه